Ladies and gentlemen, greetings from Dr. Ashok Kumar Batham, MBBS MD DCR. I'm making an appraisal to you on the use of anti-epileptic drugs for non-epileptic disorders. A case of reverse engineering wherein new indications for old anti-epileptic drugs have been found on the basis of their mechanism of action fitting into the pathophysiology of these disorders. The common disorders where anti-epileptic drugs are used include cardiac arrhythmias, painful neuropathic conditions, trigeminal neuralgia, migraine, bipolar disorder, and generalized anxiety disorder, to name the important ones. I'll today touch upon the important ones, and if you find this video presentation useful, I'll talk about other disorders. So today I'll restrict myself to cardiac arrhythmias and painful neuropathic conditions, including trigeminal neuralgia. Rest we'll discuss in the next video. Phenidine sodium has been established as an antiarrhythmic, and it is now classified as class 1 antiarrhythmic, and it's a drug of choice for treating arrhythmias caused by digitalis or digoxin toxicity, and for this purpose it is used intravenously. It is also used in the treatment of ventricular tachycardia and sudden episodes of atrial tachycardia not responding to other antiarrhythmic drugs and or cardioversion. So we have seen that arrhythmias and the epilepsies share certain common pathophysiological mechanisms. Both are episodic and both are caused by excessive abnormal discharge of impulses. A similar situation prevails in case of neuropathic pain, because here the chronic nerve injury is associated with redistribution and alteration of sodium and calcium channels that predispose neurons to sensory pathways to fire spontaneously at inappropriately high frequencies from ectopic sites in a way similar to epileptic hyperexcitability. Anti-epileptic drugs with effects on voltage-gated sodium channels such as carbamazepine, oxcarbazepine, and lamotrigine have been found effective in treating neuropathic pain. Gabapentin and pregabalin relieve neuropathic pain by selectively binding to the calcium channel subunit alpha 2 delta that are overexpressed in sensory neurons after nerve injury. Clinically, gabapentin, pregabalin, carbamazepine, oxcarbazepine, lamotrigine, and valproate have been found effective. But as far as the regulatory authorities are concerned, the US FDA approved pregabalin for use in neuropathic pain in 2005, and according to US FDA, this drug can be used in diabetic neuropathic pain, post-herpetic neuralgia, neuropathic pain associated with spinal cord injury, and fibromyalgia. Gabapentin likewise has been recommended in its guideline by European Federation of Neurological Societies in 2010, and it is recommended as a first-line treatment for diabetic neuropathy, post-herpetic neuralgia, and chronic neuropathic pain. In addition to this, there is a good evidence of better efficacy of the combination of this drug gabapentin with morphine or oxycodone or nortriptyline or venlafaxine than either drug given alone. Other anti-epileptic drugs that have found usefulness in neuropathies include lamotrigine and phenytoin. Phenytoin is a very old drug, but now it has appeared in a new avatar of 5% and 10% cream that are recommended for use in peripheral neuropathy and non-healing ulcers and wounds. It's an interesting observation indeed. Coming down to carbamazepine's use in trigeminal neuralgia, it is as old as the drug, However, trigeminal neuralgia is preferably treated with carbamazepine, and phentermine may be used as a second-line therapy if carbamazepine is found ineffective or it is not tolerated. So, to conclude today, I would say that overlapping pathophysiology of some disorders and corrective mechanisms of actions of many anti-epileptic drugs are evidently responsible for the applications of anti-epileptic drugs in clinical conditions outside epilepsy. So, a new anti-epileptic drug with additional approved indications in non-epileptic disorders is being considered to have a market potential 3 to 4 times larger than that of a drug having usefulness in epilepsy alone. So it appears that new drug candidates in future will therefore be developed for both the sets of therapeutic applications, that is epilepsy as well as non-epileptic disorders outside epilepsy. With these words, I would say thank you very much indeed for giving me a patient hearing. God bless you. Thank you once again.